Hello everyone, good morning. My name is Sokolov. I'm surgeon from Bulgaria, Sofia. We have plenty of time to deal with this topic. Usually in our congresses and conferences, we are pushed by the organizers to condense all the content of our presentation within the frame of 10 to 15 minutes. Now we have as much as time as one football match. We will deal with this. I'm aware that this topic is quite far from your professional activities, but I hope it will be some kind interesting for you. So about our university, I work in Medical University in Bulgaria. It's a public university founded in 1917. We have more than 6,000, 7,000 students. Our motto is Salus Aegroti Suprema Lex in Latin, which means the safety of the patient is the supreme law. Our university is periodically evaluated and certified by some national and international evaluating organizations, and we received every year some specific certificate for teaching and research activities with many wins during the years. This year, we are the university number one amongst the 4 Bulgarian universities in this prestigious rankings organization, Times Higher Education Rankings, with excellent positioning in those international rating databases. We have several faculties, Faculty of Medicine when I work, dentistry, pharmacy, public health, some branch in the countryside, and the College of Medicine. Our students, after the 6-year course, get some educational qualification degree of Master, MD, Medical Doctor. I would like to show you some short videos about the experience of our foreign students. We have foreign students from 23 countries all around the world. Let me show you their experience. Another one with their feedback about our university.
University life. At the moment I have a few mid-exams, so it's a little stressful, but definitely at the start it was really, really enjoyable. And meeting everybody and meeting the teachers, you know, the teachers really welcome you. It was great. The students are great, you know, especially my group, coming from my group, they're really good. And even from other groups, you know, you really dwell with other people because, you know, everybody's from a different background, but the diversity is there. I mean, there's a lot of people that you can really meet, you know, Germans, Italians, Greeks, you know, it's great, and even Bulgarians, of course.
University life is difficult, but you get used to it. It's because you're in a different environment, and it obviously moving country takes getting used to.
What I like about studying in Sofia Medical University is there's a lot of chances for you to show your capabilities. It's not the end of the world if you fail an exam, but you are always being checked up on, and someone's always on your back to make sure that you're on track so you don't fail. So there's a lot of support throughout with the professors and even your peers. The students in the university are extremely multicultural. There's a lot of diversity here, a lot more than I have seen in my friends' universities back home in the United Kingdom. There's a lot of societies that also, you know, are like show that are there for the people that are from different places. There are many. They are all, you know, catered for certain things. So you'd have ones that for charity or for certain hobbies or, you know, religions and stuff like that. And it gives you a chance to be able to experience things outside of the university. There are loads of, you know, events that they carry out so that you're able to see, you know, what life is out of university, but also maybe abroad for some certain societies.
The other students in the university are great. Since it's very multicultural, there's a large body of diversity in this university, people from different races, countries, religion. Everyone's really nice and sweet and welcoming towards you, especially the older years. They welcome you because they have different societies over here, and you get to make loads and loads of new friends regardless of their gender, their race and their year.
University life, mostly in the first 2 years, you have to study a lot. You have to get into studying, for example, as well. So you first have to learn how to learn. That's really important. In Germany, you're 1 out of 1,000 students maybe in the university. So here you mostly, like maybe 80% of the time, you study in your seminar groups, which are about 11 people. We actually got to choose our students in the beginning of the semester. And we're like a little family here, and everybody is able to help you. If you ask anyone in the university, they share their information. They are really kind. You can always go to the professors as well. They will answer your questions. And you have the seminars for yourself. So if you have any questions whatsoever, you can go to the professor in the seminar and ask them everything you want to know. And they're really like keen on actually giving you information. My favorite subject so far is anatomy, because I haven't really seen anything like it. We didn't have it in school in Germany either. And it's really interesting to know what the body is constructed of, and you see a lot in the classes.
My favorite subject in the university so far is cytology because of the professor himself. He makes the subject really fun with all the enthusiasm he puts in it, and it's just a fun subject. It's something I really enjoy.
Learning Bulgarian is definitely very interesting. You know, coming to a new language, a new country and a new language, it's really interesting to find out more about it. And each day you learn more and more, and my teacher's really nice about it. So yeah, I really enjoy Bulgarian so far. If I had one really good tip, it would be to definitely speak as much Bulgarian, even just to, you know, the people at the stall and people in school, and definitely to your teachers.
I'm doing medicine, something I've always wanted to do. Like before I came here, I didn't know what I was gonna get myself into, but I made so many new friends, so many new memories. So never let go of opportunities that you could take.
I always think that if you've thought of it and you've hesitated to do it, then it's better for you to do it rather than not, because you might regret it later and you'll see that you've wasted a chance that you had. you'd either get in and it's great, you got in, you got what you wanted, and if you don't, at least you've known that you've tried and that it's not something you've wasted or regretted later on.
If you're thinking about applying for medicine, you can do it here in Sofia. Nothing to be worried of. The city here or the atmosphere here are so amazing.
The education process of medical students is organized in 3 stages. Our team is interfering in this process in the 2nd and 3rd stage. We teach students in the 3rd course, 3rd year of the propedeutics, the basics of surgery, and the 5th and 6th course, special clinical surgery. The final year, they have the pre-graduate medical internship, which ends with several state exams. One of them is surgery. In the structure of the medical university, there are 12 university hospitals. I'm working in Alexandrovska University Hospital, which is the oldest and the largest. This is the main entrance to the yard of the complex of the hospital with the emergency center. Our department, in our hospital, we have 33 departments. One of those is surgery department. We hope to save the view of the building from the past till present days, and we combine the old school vision with modern technologies. We have 2 yards with 50 patient beds. This is the main lobby with the auditorium entrance, the secretary office, the on-duty office, the entrance to the operating theater. We have 5 operating rooms. This is the corridor into the operating theater. This is room number 2. We use it for emergency cases. This is the office when I sit. I never call this is my office. This is the office of this person, this Professor Alexander Stanishev, which is the founder of our department. He has graduated in medicine in Austria, Vienna. He's been Minister of Health in Bulgaria till 1944, when the communists came in power, and afterward, he has been killed by them, unfortunately. This is some old school photography. As it said, we step on the shoulders of those before us. They built everything this for us. This is our auditorium, how it looks like nowadays. We have several seminar rooms. In this, we conduct our regular morning meetings, some seminars, some theoretical exercises with students. This one seminar with me and students. This is topics of practical exercises for students for 5th course. We are responsible to conduct midterm exams with them. Some topics they have passed. We choose randomly one of them and give them to make some written exam before the final evaluation. Our students must be focused of the topics. We conduct our theoretical exercises in some informal environment everywhere around the clinic premises. This is the topics of lectures. We have 30 lectures per 1 surgical cycle, and topics for seminars in surgery for 6 years pre-graduated internship. The aim of teaching our discipline is the acquisition of some basic theoretical knowledge about the etiology of surgical diseases, the pathomorphology, pathogenesis, how diseases occurs and what's happened in the body, the clinical manifestation and development of the diseases, which are the specific signs and symptoms, what kind of diagnostic tools should we use to put diagnosis, and of course differential diagnosis. This is a very important moment because we try to teach our students to develop their clinical thinking, to make distinguish different nosology, different diseases. Of course, some methods for conservative and operative treatment, main focus of intra and post-operative complications. I will talk some words about this later, and follow-up at prognosis, especially for oncological diseases. Of course, not only theory, we try to give them some basic practical skills and abilities in general surgery. To be good teacher, not only teacher, but mentor and coach, you have to be good scholar and researcher. You have to write and publish some significant papers in good quality medical journals. Our department, we have publications in Lancet, in the British Journal of Surgery, Oncotargets and Therapy, etc., with good citation index, Hirsch index, with stable trend of increasing of number of citations. Our H index is nowadays is 19, not 17. It's important to visit some other hospitals. This is my fellowship in St. Mark's Hospital in London, which is an amazing place. Many of the leading scholar proctologists have worked there. You have to visit some workshops, and you have to organize some medical events, scientific events. Last week we organized a conference, national conference with international participation devoted to the breast cancer. We invited this Professor Sinikas Wominen from Finland. He came to us and ran an amazing course for ICG lymphography for breast cancer. I will tell you later about the ICG. We push our young residents to visit, to make their fellowships in different countries, in leading surgical centers. This from the Netherlands, Switzerland, Austria, etc., etc. This is one of my mentors, Walter Brunner, professor from Austria. You have to take part in many workshops. We have to publish your PhD thesis, and you have to rise before your colleagues every year in scientific events to show them your research results and to become a real professor. This is our scientific jury which evaluated and tested us for acquisition of academic position of professor. Those are eminent professors from different universities in Bulgaria. So let's get back to our students. We conduct some theory, interactive discussions of some theoretical topics from the program, from the synopsis. Of course, we have not to scare our patients. Be very patient to them. Very important is this junior assistant with senior assistant at the beginning of their career. Junior assistant should be supervised by some senior assistant professor during the practical and theoretical exercises to reach maximum quality of this process. Practical exercises, observation of broad spectrum of operative procedures and interventions, and detailed discussion with in specific clinical cases. Those are our operating rooms. Our students are with us all the time, from the morning till the end of the working day. We have a possibility to show them specific high-tech diagnostic and therapeutic invasive endoscopic procedures, fibrogastro and fibrocolonoscopy. In this room, we detect many of cancers into the GI, gastrointestinal tract. We have to show them how to do those practical skills. Surgery is simple thing. We cut and we suture and make knots. We have to show them how to make these knots.
Fourth finger like this. Up. Can you see? This is the right surgical right knot. It should be like this for your first knot. And tighten with the tip of the fingers. Like, okay? Try it.
You're gonna try this later. And we show this process in vivo, in real-time operation.
Make a record. Yeah,
This abdominal wall closure at the end of the surgical procedure. We show them how to suture and how to tie surgical knots. There are different types, interrupted, running sutures. We will see later in your practical activity.
Okay.
And afterward, they have to do this by themselves, interactive, we help each other how to do all this. Our students are with us every day in our broad spectrum daily operative activity, in open surgeries, laparoscopic surgeries. About 70 to 80% of our activity is minimally invasive laparoscopic surgery, which is interesting for them to become masters. Small size, but masters. We do proctology for some students which express some interest in surgery. We scrub them into our operative team during the surgery. It's quite interesting for them. This proctology surgery for perianal fistula, this abdominal wall hernia surgery, repair of the abdominal wall with mesh. We are able to record all our surgeries with this device, and the next day or whenever we want, we can replay the tape of the record of the surgery and discuss some specific details, specific points with the students from this specific case. Laparoscopic, you can see students around. Laparoscopic colorectal surgery for low rectal cancer, this perineal part of the surgery, with discussion with students, what should we do, what is our next step. We show them some specific surgical devices. Those are staplers, mechanical suturing machines for open and laparoscopic surgery. They can try, they can use them in some mannequins. We show them interesting cases, this fibropurulent peritonitis, life-threatening condition. One of good points is that our students, we let him stay with us during our on-duty shifts, day and night. The interesting cases come during the night. They are with us. They see the coming of the patient into the emergency center. This is due to perforation. You can see perforation of the bowel. A little bit disturbing footage, but don't worry. They have to see all the process from the admission of the patients, how we put a diagnosis, what kind of lab test, what kind of imaging test should we use, how we take a decision about our behavior to this patient. Do we apply conservative patient, active observation, or emergency immediate surgery? This feculent peritonitis due to perforation, we have specific devices, this life-threatening condition with lethal rate more than 80%. We have a VAC-PAC system. We show to our students this system, how does it work. With implantation into the open abdomen, this vacuum system for good drainage of all the debris and secretion and good perfusion of the things, and this machine could save the life of this patient. We show them how we apply this system, specific sponges, sterile, specific folia, and vacuum system. This colostomy, the bowel on abdominal wall formed the colostomy, and this is the VAC-PAC system with good drainage and colostomy of abdominal wall with some collector back. We show them more interesting cases, large tumors, this spleen tumor, this large bowel tumor with synchronous cancers along the length of the tumor, specific surgeries. In some cases, they will never forget. This severe soft tissue infection causes septic condition with this patient, elderly female patient. She survived after our treatment. Some cases, literally from last week, again emergency cases, bowel obstruction syndrome due to lower rectal cancer with severe distension of the proximal part of the bowels. This is the so-called car tire bowel. If we didn't operate this patient, on the next day this bowel will be burst with feculent peritonitis with death rate more than 85%. And the students were there and they were part of this process. We have many high-tech devices. This is the ultrasound machine, the last generation we make with high-quality imaging, a very important device in process of putting in diagnosis. We are the only clinic we have this ultrasound device for transperineal and endoanal ultrasound diagnosis with magnificent imaging for what happened into the perianal area. Some trauma, disruptions of the external sphincter apparatus after childbirth, of course, perianal abscesses and fistulas to better plan our upcoming surgery, this surgery, Lone Star retractor surgery of the perianal abscess. This is my last book devoted to the perianal abscess and fistulas. We have special devices for measuring, long-term measuring, 24-hour monitoring of the acidity of the lower esophagus part and motor function of the esophagus. This is how looks like the application of the probe, nasoesophageal probe to patient. With this device, we can analyze the results to take a decision if this patient needs some anti-reflux surgery. We do this along with our students, all this process. I'm very proud of this. Thanks to the management of our university, we have last generation simulator for laparoscopic surgery, very interesting device with 3D glasses with the possibility to, we push our students to work with this device to gain some skills in the laparoscopic suturing, laparoscopic dissection, hemostasis during the laparoscopic abdominal surgery, etc., etc. This is the ICG, indocyanine green. We use it in several directions. This is a breast cancer patient. We have device special console to detect the fluorescence from indocyanine green with near-infrared camera, spatial camera. We apply ICG around the tumor in breast cancer to see what exactly is the lymphatic pathway from the tumor to the so-called sentinel lymph nodes, because nowadays there is a switching of the medical behavior in breast cancer patients from surgery to chemotherapy, and especially target biologic therapy with monoclonal antibodies. And it's quite important to take decisions: should we perform total axillary lymph node dissection or only sentinel, which is quite important for our patients because after total lymphadenectomy of the axilla, there is a severe lymphedema and low quality for those patients. This is how it looks like. Fluorescence mapping of lymphatic pathways from the tumor to the sentinel lymph nodes. We do this in front of our students. We show them all the process. Those are our students during this type of surgery. We perform double tracing of sentinel lymph nodes. We use ICG, and you can see on the table of nurse table the gamma probe. This is the gamma probe. The previous day we send the patient to the radionuclide laboratory. They apply some radionuclide, technetium, around the tumor, and the next day we can use both ICG and this gamma probe for better localization of those sentinel lymph nodes. We extract them and send them for histopathology investigations. Thanks to this console with near-infrared camera. We use ICG not only for breast cancer, for colorectal resections, especially for left side colon cancer, before resection and forming of the anastomosis between proximal and distal part of the bowel. We check the good perfusion. We should cut the bowel in this green area. It shows us the good perfusion, which will save us from one of the most severe complications, insufficiency of the anastomosis with leakage of anastomosis, this very disturbing complication with high death rate. Literally next week we will receive our first robot system in our department. This is the Vinci robot on February 17th, this next week. We are very excited of this. We will start doing robot surgery, of course, after certification. And we will work in this device with our students again. This is how the robot looks like. Those are 3 to 4 arms. This is from outside for patient. The surgeon stays on the robot console with 3D visualization. There are monitors, and the imaging is projected on the monitors, and the students could see everything which happened inside into the body. The good of the robot is a better visualization, 3D visualization, and the movements, 360 degrees movements, which surgeon hands could not do. By this robot system, we can do mostly everything into the abdominal cavity, especially for lower rectal cancer, especially for narrow pelvis, in some obese patient. This is a perfect device with high quality surgery. Some other tools, we are very happy with this. It's not interesting only for our students, but for us. This is a 3D plura view. In this device, we can put all the information, all the imaging from CT scan, computer tomography, magnetic resonance imaging, ultrasounds. There is a specific software, and we receive real-time imaging of this patient. We can move in all directions in 3D visualization to see where exactly the tumor is. which are the feeding vessels, we should cut them, which are the specific structures around the tumor, we have to save them. Very, very useful for planning of some large volume surgeries, especially pancreatic cancers, liver cancer, high volume surgery. We use all these laparoscopic simulator consoles with our students. They are very happy to try this. We organize and conduct some seminars and some courses with them. We show them how to do, not only me, my assistants, my whole team, and we give them some certificates, and they are very happy after finishing this course. In our university, not we, our students organize every year student congress, international student congress, with there are participants from Africa, Asia, South America, etc. It's interesting event they organize. We are only evaluators, we are mentors, and we make some evaluation of poster sessions in oral speech sessions. Very, very good event. They could make some connections with students from other universities, which is very interesting for them. One of the topics we pay attention for our students is surgical complications and medical errors, surgical errors. Every day at our work, we are on the razors of the edge, and the limits what if possible and what if permissible to do. Complications are disasters for us. We have to show them to our students. This after laparoscopic inguinal hernia repair, hemorrhage, bleeding. We show this case to them. They were there. Complications are very important because they directly affect the patients, his relatives, and reciprocal and proportional multilayered negative impact they have to the training team, surgeon and intensive care unit team. They fell those errors in the so-called gray zone about the interpretation, the study, documentation, and complex treatment of them. No one talks free and open for surgical errors. They are quite important for us, and we teach our students how to prevent them and how to deal with them when they occur. Very important thing is the communication between all those stakeholders. Surgeon, each colleagues, they could be friend, they could be enemy in this situation. Patient with patient-related persons, his relatives. A very important institutional management, the manager of the hospital. In this situation, they could react in different directions. Of course, some auditing and controlling health structures, and of course media, journalists. Very important. Why? Because more than 50%, the half of the adverse events are related to surgery, and more than half of them could be prevented. They cost only in US more than $20 billion every year. They could be consequences, procedural failures and complications. We have to avoid procedural failures and complications. What could we avoid? Why they are important? Because they directly affect the surgeon. Not only the surgeon, but his family, his relatives. He could feel some rage, guilt, inadequacy, depression, even suicidal thoughts. How to work this person after this pressure. We have to analyze all the adverse events and surgical errors. We have to identify the cause and develop some preventive strategies. Some samples, this is my case, patient, male patient, after gastrectomy for gastric cancer, 3 months later, he called me with severe abdominal pain. I admitted him in hospital. We make several procedural investigations. One of them is plain radiography, and we saw this forbidden instrument inside the abdominal cavity. Emergency surgery, of course, real laparotomy. We found small bowels goes through the ears of this instrument with incarceration, strangulation, ischemia, necrosis of the bowel. I should resect this part of the bowel, make anastomosis, which is quite dangerous for this patient. Happily, everything finished well, without any legal consequences, but the adrenaline from me was high level. That's why surgeons die in around 50, 60 years by heart attacks, because of the adrenaline every day. Some other cases, forbidden, some gauze left inside into the abdomen from some other hospitals. We are a tertiary referral center, and many patients come to us from other parts of the country. We found this forbidden foreign body which cause abscess and local peritonitis. Some other cases, young female patient with huge, there is no pointer here, huge adrenal gland tumor with dislocation of the liver, this liver and right kidney. During the surgery, we have to cut the feeding vessel to this tumor before extraction of the tumor. But because of the large size, locally advanced tumor and dislocation of surrounding organs, during this surgery, there is a ligation and cutting of the feeding vessels of the right kidney, which is quite dangerous. It's good to see during the surgery this problem, to identify right now, and to correct this problem by implantation of the chrome prosthesis for restoring the feeding vessels of the right kidney. So, prevention of those medical errors, surgical errors, checklist. We have to adopt and implement and strict adherence to performing of checklist before incision, during the surgery, before patient leaves operating room, with many steps. Counting and weighting of instruments, using radio frequency labeled gauze in case of forbidden foreign body, and surgical timeout before surgery to see if this is the correct patient, the correct organ we will intervene, the correct side, left or right inguinal hernia, etc., etc. We borrow those rules from high-risk industries like aviation, space activities, military and police, oil platforms, etc. I'm a huge fan of National Geographic Channel series of air crash investigation. I know everything about this because they are similar to surgical errors, very similar. One disease, one catastrophe, never caused by only one reason. There are series of multiple small errors, multiple negligence of rules, some coinciding events, and complex at the specific period of time cause a catastrophe. You know this catastrophe from a few weeks ago in United States. There are two. Like in aviation, they use checklists before start engine, checklists before takeoff, checklists before landing. It's the same in surgery. they use simulators. You can see how complex and sophisticated this is the cockpit of 777 Boeing with many devices there. It's the same in operating room. This is our alpha operating room, many devices. But we tell every day to our students that no matter how many high-tech devices you have and how modern they are only one supportive element to the surgeon's eyes, brain, and hands. Of course, in contemporary surgery, especially high-volume surgery, laparoscopic and robotic, simulators are quite important. I was quite happy to have a friend which is instructor in Lufthansa and examiner for pilots. He put me in this simulator, 100% VR reality visualization. This is simulators in Sofia Training Flying Center. I was here. This is instructor, my friend. Those are real pilots in their training sessions. They performed during this, I was there during the night, is this, 4 hours. For 4 hours, they made 13 potentially fatal mistakes. There is a hardware and software which could simulate every situation in aviation. It was quite interesting for me there. Those are real pilots. They work every day. This is me driving airplane. Amazing experience. It was wonderful. So in the surgery is the same. Many platforms for simulation of some laparoscopic or robotic surgical interventions. This is in Davos. This is the building where G7 has their summit. We were there for with our students for this simulating center for lap surgery. We use dry lap for plastic organs, robot simulations, laparoscopic, and wet lap, cadaveric lap. Those are real cadavers. We can use with our students some devices, machines, staplers, to use how they work, how we could perform anastomosis, how should we perform dissection of vessels in real cadavers. This in Acıbadem in Istanbul, Turkey, amazing private center, private university. In the police is the same. This is my brother. He is chief of the special SWAT team, anti-terror team in police. They do their training every day to achieve high professionalism, to avoid mistakes. Every day training with his team. This is his and his mates in action. They call this operation. Hey, bro, we did operation yesterday. Some journalists make a photo. I will send it. It's the same in every type of profession. That's why we push our students every day, learn, every day be focused of what we teach them, what they learn. Of course, not only students, but young residents. We push them to go through this, to walk this path of academic growth, to be good teachers. Thanks for your attention. I would like to put you a little bit into the shoes of our students. I have some instruments here to show you how to make surgical knots and how to make surgical suturing. If anybody is interested of this, I can show you. Okay. The 3/3 rule. 1/3 at the air, 2/3 to the tip, about the needle, about the thread, 1/3 to 2/3. About the branch, 1/3, 2/3. This is the correct grip of the surgical instruments. We can put like this. Make crossing over. Put your middle finger like this, on this incisura, this thread like this. With the nail, you have to do it like this. This is the straight surgical knot. Straight surgical knot. Second one, press first. Push with the tip of the index. The second one, push. And make 5 to 7 knots. Different types. It's easy. If someone of you wants to try, I'm here. Thank you so much. And pull.